John or Dr. Tonkin has already advanced his catheter and wire from the right side of the patient over to the patient's left. And now what he's doing, if we can look at the live fluoro, he's advancing a guide wire down the patient's left superficial femoral artery. And we'll see it here in a minute. The wire, if you'll notice, has a little curve on the distal end of the wire. And he's using that curve basically to steer the guide wire down the appropriate vessel.
Let's pull that out and do a subtraction.
Cut back there a little bit from it. But the bottom line is the guide wires that we use in a particular case like this are directional. And we use directional wires because you can see from the images there are turns and curves in the arteries, and we need to be able to navigate through those turns and curves in the artery.
Well, we've got we have the sheath down, the treatment sheath now, Dr. Cleo's all the way over into the contralateral common femoral, so basically at the level of the groin. You can see the little marker tip on the end of our sheath there. We're going to leave that just above the superficial femoral. And we're going to put a distal protection filter, which is just a sort of like a little wind sock made of mesh metal. We're going to deploy that down into the popliteal artery here, kind of below the level that we're treating. And the purpose of that will be to catch any debris that might otherwise embolize to the foot during the course of our procedure. So again, I'm going to get us a subtraction image here so we can sort of, a roadmap image rather, so we can sort of get the lay of the land. There we go. And we'll take a 5mm Spider X filter, please. We're going to get this diagnosed. Well, Dan, let me run this wire down just a tiny bit further there.
While John's working here, he's at a point that he's trying to cross this lesion. Two things. First, she developed a large ulceration on the right leg, as we talked about earlier, which we fixed the right leg. We predominantly healed this ulceration, but after we fixed the right leg, then the patient noticed she could only walk about 100 yards or so before her left calf started hurting. It basically felt like her leg was cramping up or her calf was in a vise and pressing down. She would walk about 100 yards, she would have to stop, rest, the pain would go away, and then she could continue walking after that. Basically, she was having symptoms of claudication on the left. From that point, she underwent a simple blood pressure test called an ankle brachial indices, or ABIs, which showed significantly diminished blood flow at the level of the left calf. From there, she underwent a CT angiogram that documented the lesion in her distal left superficial femoral artery, and subsequently she arrived here, and we're going to fix this lesion hopefully in a few minutes.
Coming down our catheter now, Dr. Cleo's with the Spider filter, and that has markers on it to show you the portion that, and you could just see it spring out into the vessel there, and it looks exactly like, basically you can see it's basically a wind sock made of mesh metal with markers on the front and then the tip. There's a little bit of wire that sticks out the end of that, and we've got that in the popliteal below the knee joint level, so that's below the level we're going to treat, and above the branch vessels, pull that for me, above the level of the branch vessels in the calf. So really, by putting that in place there, we've protected the foot and the distal muscles of the calf from any debris that might break off during the course of the procedure. So that's in good position now.
John's just getting everything set up here. We noticed a little bit of disease on our CT angiogram in our proximal superficial femoral artery. So he just wanted to take some oblique images of it and make sure there wasn't vessel overlap and we're missing some significant disease up higher.
What I think we're going to start with is we're going to begin, generally the rule of thumb is that you begin treating proximal disease and then you progress downstream. And although there isn't any critical narrowing in this area, there is some disease in there. We know it to be fairly concentric, so meaning fairly likely to be physiologically significant based on the CTA. So I think we're going to make some cuts through this proximal area, and then we'll go down and get that more severe lesion just above the knee joint. But we're going to focus right here on this proximal disease, so I'm going to do some magnification views so we can get a nice mask, and then we'll be we'll be proceeding with the atherectomy. Well, her contralateral leg had very severe disease. She had a complete occlusion of the vessel, not just areas of stenosis or narrowing, but a total occlusion of the vessel over fairly long length. When you're dealing with that, it can take quite a while to resolve that. We've got our atherectomy device in position, and if we can go to the left, the fluoro, the live fluoro screen, there we go. And you can see the catheter, the atherectomy catheter has a little notch, which is right at the very top of the screen. There's a little notch in the catheter. That's where the cutting blade is. We're going to bow against the wall of the vessel and then turn the blades on, and we're going to sort of shave the plaque off the inside of the vessel. So we made a few passes with the atherectomy catheter there. Hopefully James can clean some of the atheroma out of the tip of the device.
Oh, look at that. Okay, let's, you're seeing him pushing the plaque out. This is the bacon that you had for breakfast, the cigarettes that you smoke, all that bad stuff that you're doing. This is what builds up inside of your vessel. You see it's white, it's glistening, it's fibrotic, it's not a soft, mushy plaque that you think about when we're talking about arterial disease. This is the stuff that narrows the vessel over time. And if she does not stop smoking, or she doesn't change her lifestyle or become more active, this will return. But basically what you're seeing is that atheroma that we showed earlier now being shaved out of the vessel.
Yeah, we've got one little area of mild narrowing about 2/3 of the way up the screen that we're going to make a few more passes, a couple more passes through there, and then let's go ahead and load the catheter on there, James. And then we're going to go ahead and proceed.
Now what Dr. Tonkin is doing at this moment is advancing the atherectomy device back through the sheath that he put in earlier, and you got to make sure the blade is inside of the atherectomy and that you're not cutting the sheath itself. And once he gets it in position, we're going to go to live fluoro, and we're actually going to see him pass the catheter down through the area of abnormality, which you see at the upper 2/3 of the screen right now, and we'll see the device actually being activated.
You can see on the live fluoro, Dr. Cleos, we've turned the little notch out there lateral in the vessel,
right?
And we're going to get it poised really in the area where we've got that little bit of residual narrowing, and then we'll go ahead and we'll turn it on, and we'll make a pass or two through that area again. Okay. All right, James, go ahead. All right, so you can see the change in the configuration of the little notch.
You can actually hear the buzzing too.
Okay.
That's the motor spinning the little cutting blade.
We're going to bring it back. We're going to spin it around so we get the opposite side of the vessel.
That's exactly right. So you can see he's changing the aperture to the other side, the little fenestration, and when he turns it on, the blade comes back, spins through the plaque, and actually pushes the plaque hopefully into the nose cone of that little catheter.
Let's just do a little follow-up run right there. And we're administering during the course of the procedure, Scott, we did prior to starting the atherectomy, and now we're adding a little bit of heparin, which is a blood thinner that we give intravenously or intraarterially during the course of the procedure to keep the blood real thin so that we don't add any propensity to cause thrombosis or clotting as a complication of the procedure. Injury is one of the main reasons why people develop clots in the arteries or veins, and obviously we are traumatizing the vessel, so we're very cautious to make sure that we, and that looks very nice, that we keep the blood nice and thin so that doesn't happen as a complication of our interventions, whether it be angioplasty or atherectomy or even with stent placement in most cases. And we're going to again kind of zero in on the area of disease. Let's go ahead, let's really focus on that one. That's the one that's really causing flow issues, is that one right in there. So let's go ahead and do a full strength contrast, do a road map.
So we're back on live fluoro, and we're seeing Dr. Tonkin has gone down and is treating the next lesion the same way that he did before, and he's passing the atherectomy device through the area of narrowing. And he's going all the way around, hopefully 360 degrees. You kind of concentrate on the area that shows the narrowing angiographically. So if it looks pretty good over to the right of the screen, you probably won't do too much atherectomy in that region. But if you see a lot of narrowing on the other side, inside, then that's what you're going to concentrate on. And you can see the little cutter actually acts like a gauge, so you can tell how much plaque is sitting inside of the vessel. So they're going to take that out. So what we're seeing right now on the screen is they're removing some more of that plaque. This is more of that bacon and cigarettes that we talked about earlier. We've shaved the inside of that vessel down, and that's what's coming out right now.
We've made a few passes through that distal lesion, Dr. Cleos. Can you pin that wire for me, Dr. Miles? And we're going to go ahead and make a few more. We've still got a little bit of progress we can make there. And then I'm hoping we're going to be done. We'll obviously do some completion pictures where we'll show everything very nicely, and hopefully everything will look good. Let's see here. Let's just show that again,
Okay.
Scott, if you don't mind. Just stay with us here for just a second, and
Okay.
we'll show just our last view. And we can, this is a directional device, so we look like we have some narrowing there on the lateral part of the vessel. So we're going to go. Dan, will you activate that for me, please? Okay, we're going to go ahead and hit it. And we're going to just take it right down through there slowly again, focusing on the lateral wall of the vessel. Okay, off. And let's do maybe one more. We'll just turn very slightly.
And he's basically, lesion is completely gone. It looks like a normal vessel at this point.
Okay. Now one of the points that, atherectomy, I'm always amazed at atherectomy being, really the only modality that we have that effectively preserves or sometimes even improves the collateral flow. It actually opens up branch vessels as opposed to closing them off, which angioplasty and stenting can do. And you can see we've got, we still have very good flow in the branch vessels in that area. I'm going to go ahead and take the catheter out just so we can get a better set of pictures.
Actually, Scott,
This
while
is,
there's...
if you want to look at that run there, Dr. Cleos.
Okay, let's go to the live fluoro again. Take a look at what Dr. Tonkin's trying to show us there.
Okay, and that's the proximal thigh, and Dr. Miles can go to the previous image. Dan, if you could do that for us, please, and then we'll show go to the previous run. It shows the distal thigh to the knee right there.
Oh, that's
okay.
great.
And now what I'm going to do is we're going to go ahead and remove the distal protection filter, the basket filter. So we're going to go down and usually do this, under careful, direct visualization. Because we have to make sure that, pin that for me, we have to make sure that basket folds into our little retrieval catheter and comes out smoothly. And we'll see if there's any debris in it. We can actually take that onto the back table again and see if we've captured anything. In most cases we do, and it'll look exactly like the stuff that comes out in the atherectomy catheter, and it would have otherwise ended up down in the foot. Okay, so we're going to go ahead and advance the little retrieval catheter over the basket, and then the basket and the wire comes out. And we'll take a look at it on the back table and see if there's anything in there. We're just going to basically, I'm going to take a picture of the groin, then we're going to close the groin with a suturing device.
Scott, I'm going to apply pressure up here. We've got a puncture in this artery, so it's arterial pressure. The size of this catheter that's going into the skin here that we were working through. And what we're going to do is John's going to take that out. I'm going to apply some pressure to hopefully stop any of the blood from coming back the puncture site while he gets the closure device in there.
Okay, Dan, you got it?
I got it.
All right, so we're leaving the wire in so we can introduce the per-close suture. We just have a good look at the groin here. You can see the small size of the incision we made, just a little nick in the skin. We have good hemostasis, and that's the end of the procedure.